Hello, and welcome to my case study on acute respiratory distress syndrome, or Ards for short. This is a life-threatening lung injury that allows fluid to leak into the lungs. As a result, breathing becomes difficult. Unlike traditional respiratory illnesses, this illness does not respond well to the traditional oxygen therapy. As a matter of fact, individuals who develop this illness will eventually be intubated and have to be on mechanical ventilation. Um, Also, to keep in mind, most people who get ARDS are already at the hospital for some kind of trauma or illness. For instance, they may be a burn victim or they may be a drowning victim. And while they are recovering from this initial or primary illness or trauma, they develop ARDS. Before we get started, I just want to take a little time to explain the outline of the case study. It says here that we'll be looking at the case study over a period of 4 days, but because this case study occurs more than extends more than 4 days, we'll actually be looking at snapshot in time over the period of the case study. This is day one of the case study. Let's get acquainted with the family and the reason why our patient is admitted to the hospital. So Avery Sparks is a 16-year-old African-American male who lives with his parents and 5 siblings. He is overweight and previously diagnosed with type 1 diabetes mellitus. On Sunday, the 22nd of August, around 10:30 a.m., the family went down to the local beach for an outing. Avery is a very good swimmer, of course. In fact, he is the only child that is allowed to swim in the deep parts without a life jacket. At the end of the day, however, Avery begins to feel weak and lethargic and lacks the energy needed to swim back to shore. Additionally, the waves had become rough and too much for him to navigate. Luckily, his brother, who was wearing a life jacket, joined his brother against parents' rules. Remember, Avery was the only person who was allowed to go into the deep parts. So Avery asked his brother to inform his dad, who was a former lifeguard, to come and get him. Avery, however, had expended so much energy staying afloat that he did aspirate water into his lungs. However, his dad was able to come and rescue him before drowning. His dad performed CPR and a patent airway was established. Um, Avery was uptended and not easily aroused, however, and at that time his dad initiated 911 and they arrived in 7 minutes. When the paramedics arrived, they were informed that Avery is a diabetic. His blood glucose was checked, and found to be 34 milligrams per deciliter. Avery was given glucagon subcutaneously and immediately transported to the local hospital. Avery was given some care by the EMT. So these are his pre-hospital care. Glucagon 1 milligram subcutaneously. He was vented to 100% oxygen. 2 IV access were also placed, an 18 gauge needle for 50% dextrose, which was not given because he had already gotten glucagon 1 milligram subcutaneously. And also a 23 gauge needle was placed for broad spectrum antibiotic, which was not given because that is not something that would be done via the EMT. When Avery presented to the emergency room at 15:35 on the 22nd, he was still hypoglycemic and in and out of consciousness. Avery's in-hospital vital signs are as follows. Glasgow Coma scale of 10, O2 saturation of 92%, blood pressure of 140/76, very tachycardic at 132 beats per minute, His temperature was 97.6 and his blood glucose was 55, which is an improvement from 34, um, because of course he got that subcutaneous glucagon shot, but he is still obtunded and not easily aroused, so he's not out of the woods just yet. When Avery comes into the emergency room, he is obtunded and incoherent, so the priority of the nurse is to try to secure his airway, breathing, and circulation. So Avery is placed on oxygen and his O2 saturations are continually monitored. The next thing that they need to do is to make an effort to stabilize his blood glucose level. So a bag of D50W dextrose was started, and a chest X-ray was done to check for fluid in his lungs. Avery will need some labs taken, for instance, a CBC, a complete blood count, which measures the number of blood cells in the body. It measures the red blood cell, white, and platelets. And Avery's white blood cell count, for instance, was 160,000, which is within the normal range. A complete metabolic panel is another one that needs to be done, and this is done for diagnostic purposes, and it may be prescribed when you have symptoms connected to your kidneys, liver, or metabolism. And there were no remarkable findings in Avery's CMP. A urine analysis also will be performed, and his were negative for bacteria, parasites, blood cells, or any urinary crystal. These are the medications that may be prescribed for Avery. Dexamethasone, which is a steroid to treat any possible inflammation that might occur. Remember, he did aspirate some water, seawater for that matter, into his lungs, and dexamethasone may be prescribed. Ciprofloxacin, this is a broad-spectrum antibiotic that may treat any possible infections, and of course D50W dextrose to help maintain his blood glucose levels. So from the time that Avery comes into the emergency department until he leaves, assessment should be an ongoing process. For instance, he should have an emergency department evaluation that includes a thorough clinical history and a physical examination. Also, the nurse needs to assess the patient's mental status. Changes could signal a buildup of toxins or electrolyte imbalances, or mental status changes could be related to his hypoglycemic state. The nurse also needs to assess the patient's blood glucose level, especially after the administration of dexamethasone, which is a steroid, and it may cause hyperglycemia in this patient. And even though at this point he is hypoglycemic, in addition to the D50W that he's taken, with this dexamethasone, it might tip him in the opposite direction. So his blood glucose level should be checked, and it should be checked continually. After reviewing Avery's chest X-ray, a medium 15 to 20 millimeter area of opacification was noted. Additionally, Avery's blood glucose levels decreased despite administration of dextrose, so he was started on continuous IV dextrose with frequent blood glucose level checks. He was hospitalized in the intensive care unit for overnight observation and further treatment. By the 24th at 0900, which is a little less than 2 days from the time of his admission, he was transferred to the med-surg unit where he was doing better. Um, Continuous glucose monitoring was done, and Avery's average blood glucose level was consistently between 80 and 90 milligrams per deciliter. So around the 24th, around 1900, the hospitalists from the med-surg floor informed Avery's family that he was doing much better and would be discharged pending a second X-ray scheduled for 2200 that evening. However, at around 2100 on the 24th, which is about an hour before Avery was scheduled to have his X-ray, his breathing became labored. He was irritable and lacked focus. His blood glucose monitor indicated that his blood glucose reading um, was 90 milligrams per deciliter, so that was not the problem. So then the nurse checked his O2 saturation, which had decreased from 95% to 90%. She then checked his lungs, which were which the sounds were diminished, but he had normal to sparse random crackles. The nurse also noted that he had mild ear hunger and he was tachypnic, around 22 breaths per minute. So she administered oxygen via the nasal cannula at 6 liters per minute. After she administered the oxygen, the physician was notified and the nurse continued to monitor his progress. About 90 minutes later, Avery became tachycardic, 115 beats per minute, severely tachypnic, cyanotic with frothy sputum discharge. His O2 saturation was now 88%. His mental status declined and efforts to breathe led to a chest retraction. Avery was put on a non-rebreather, but his situation did not improve as evidenced by his O2 saturation that was now 82%. He was found to have refractory hypoxemia, which just means resistance, which is resistance hypoxemia that does not change with the administration of oxygen therapy. A code was called that required Avery to be intubated and mechanically ventilated via positive and expiratory pressure. A chest X-ray showed hypoxemia evident by bilateral consolidation with ground glass opacification. Acute respiratory failure was confirmed, secondary to Ards, and Avery was transferred to the ICU at 23:15 on the 24th. So these are Avery's labs and vitals for day 2. His throat culture was positive for group A hemolytic strep, which is a bacteria that is commonly responsive, that is usually responsible for acute respiratory distress syndrome. His urine culture was negative. ABGs indicated respiratory acidosis, and his blood pressure was 113/75. Heart rate that was tachycardic at 130. O2 saturation, which was confirmed at 88%. His temperature, which was 101.6, which confirms and indicates that he may be fighting an infection. And his respiratory rate is 25, which also indicates that he may be fighting a fever or some type of infection. So these are the medications that Avery may be prescribed. Spironolactone is a diuretic for fluid volume overload, and this may occur especially because he is unable to eat because he has because he is intubated. So it is necessary for him to have enteral feeding. So the spironolactone will prevent fluid volume overload. Propofol also will be prescribed for sedation. Amoxicillin for group A strep. which now that we know that that is the bacteria that is causing the infection, now we can prescribe a specific antibiotic for that bacteria. Um, he will also be on famotidine to prevent the development of ulcers while he is intubated. And of course, vecuronium, and this is a blocking agent to prevent damage to the larynx, so that it can help his muscles to relax, and of course, that will help to prevent any damage to his larynx. The time is 0800 on the 26th. At this point, Avery is stabilized and recovering in the ICU. His vitals are 123/80, heart rate 92 beats per minute, O2 saturation of 95%, temperature of 99.6, and respiration of 20. Because he is sedated, he was catheterized and had placement of an NG feeding tube. Unfortunately, in terms of medical management, no drug has been proven to be effective in preventing or managing Ards. The chief treatment strategy is supportive care. So Avery's nurse is about to enter his room to administer care, and these are his assessment and patient care goals. So the things that he needs to prioritize and focus at this point in Avery's healing is lung assessment, providing adequate nutrition, aspiration pneumonia prevention, ventilation weaning assessment, preventing volume trauma, and managing I's and O's. So Avery's nurse will assess his lungs to gauge any improvement or worsening developments. This also includes making sure the head of the bed is 30 to 45 degrees to prevent aspiration pneumonia. He will also perform, along with respiratory therapy, daily sedation holds to assess if Avery is ready to be extubated. This keeps sedation to a minimum and engages his ability to breathe on his own and his ability to be weaned off of the ventilator. In addition to this, Avery's nurse will provide adequate nutrition, but before he attempts to do so, his nurse will first assess for abdominal distension. He will also do this by checking residual volume, and if the volume is more than 150 mLs, the feeding will be held. Avery's nurse priority is also to prevent volume trauma. The nurse will check the ventilator settings according, of course, to his scope of practice, but he should be familiar with the alarms and actions taken when an alarm sounds. He will locate suction equipment and a bag valve mask. Finally, he will be able to compare settings to the ones prescribed in the order. He will also manage Avery's I's and O's to prevent fluid volume overload or fluid volume deficit. Patients who are sedated often need a urinary catheter placed. It is important for the nurse to keep track of the patient's intake and output, and Avery's nurse first assesses the appearance of the output and notes the cloudiness, the appearance, any odor, and the amount of output that Avery has. On the 26th, Avery began his recovery from Ards in the ICU, and even though he had a significant event less than 48 hours ago, his vitals were already trending in the positive direction. He will be maintained on amoxicillin, propofol, spironolactone, famotidine to prevent the development of ulcers while intubated vericonium. Avery's nurse also will look and continue to monitor his ABGs, which are also trending in the positive direction. His pH is 7.4 and his bicarbs are between 22 and 26. At around 9:35 on the 26th, Avery's attending physician was encouraged with his progress. Avery has performed well on his daily sedation holds and ventilation weaning, and is breathing on his own. He was subsequently transferred to the med-surg floor and is ready to be discharged. His vital signs and labs are within normal range for his age. The nurse will complete a final evaluation before her shift ends. The nurse assessed his lungs and they were clear with no crackles. The nurse also monitored for pneumothorax. A high positive end expiratory pressure can cause the lungs to collapse. The nurse assessed his vital signs, including his O2 saturation and pain level, and Avery's labs and vitals show that he has recovered from his acute respiratory failure. His labs and vitals indicate a complete recovery. For instance, his heart rate is 72 beats per minute. His O2 saturation is much improved at 96%. His temperature indicates that he is no longer fighting an infection. Also, his white blood cell count is within normal range, and that also indicates that he's no longer fighting an infection. His pH levels shows that indicates that he does not have respiratory acidosis. So all in all, his labs and his vitals indicate that he is ready to be discharged. So Avery is ready to be discharged, but before he does, he needs to meet some criterion, which is, number one, proving that this was an isolated incident, meaning a single episode of hypoglycemia without recurrence. He understands how to prevent future episodes of hypoglycemia, that he has and he also needs to prove that he has eaten a full meal during the observation period. Additionally, he will be sent home with a continuous glucose monitor to better monitor his condition, and he will be sent home with a brochure that educates him on the recovery process as it relates to acute respiratory distress syndrome. So this concludes my case study on acute respiratory distress syndrome.